Welcome to today's surgical video. In this session, we will demonstrate the thoracoscopic repair of congenital diaphragmatic hernia in a newborn. The infant is placed in right lateral decubitus and inserted a 5 mm port in telescope at the mid-axillary line in the fifth intercostal space. Two additional 3 mm working ports are inserted anteriorly and posteriorly. CO2 insufflation initiated at low pressure 4 to 6 mercury while closely monitoring ventilation and hemodynamics. The bowel loops you can see, but other organs are not visible. The lung was hypoplastic. So now careful atraumatic handling of tissues is essential to avoid injury. Then this first step is reduction of abdominal contents using gentle graspers. We gradually move the organs back into the abdominal cavity. Each structure is carefully manipulated to avoid traction and damage. You can see the colon is little bit adherent. And but it was not completely forming the posterior wall. So there was a leap of posterior wall tissue. So we plan for see the reduction is complete. The diaphragm defect is well exposed and can be inspected. Repairing the defect. Now we now focus on repairing the defect. If the margins are adequate, a primary repair is performed. In this case, we can do a primary repair using a non-absorbable sutures. Usually interrupted sutures are preferred. Mostly prefer to do ethibond, or you can use silk or prolene sutures. So knot tying can be performed either intracorporeally but extracorporeally. But in this case, we have chosen to go for intracorporeal suturing. Large defects, prosthetic patch repair may be required to close the gap. But in this case, we are able to achieve primary closure with direct suturing. Not to take a bite in the intestines, mostly the colon forming the posterior leaf. This minimal invasive technique has revolutionized pediatric surgery, offering faster recovery, less pain, and improved cosmetic results when compared to traditional open surgery. And you can see the interrupted bites are taken. Keep patience while taking bite. The sutures are put inside to the thoracic cavity directly uh, from the skin side. And in this case, we have used 30 silk sutures with interrupted manner. First, the suture was taken was to in the mid part as the column was protruding inside to the chest wall, and later we have taken interrupted sutures. So keep patience while suturing because there is a small space, and the suture length should be kept minimum with 15 centimeter maximum for better suturing. In this case, we have used 4 sutures for suturing the defects. Suturing in the sometimes in the apex part, upper part, the suturing becomes difficult, and the diaphragm leaves also deficient. In that cases, if it is deficit, there is deficiency of the leaf. There is not mm, well formed. Then you have to take suture with the chest wall or around the ribs, or you can go through the suture around the wall, and you have to bury the suture in the skin. So by taking interrupted sutures, now the diaphragm has been repaired. You can do a good repair. I've done hemostasis, and now you can put a chest tube. And in this child, the chest tube was kept for 6 days, and post-op they kept on elective ventilator for uh, 2 days. After that, the patient extubated and started to feed on day 3. The child was discharged on post-op day 7, and on follow-up, the child is baby is doing well. So thoracoscopic repair is very much feasible and can be done in 1 and 1.5 hour. We took it around 1 hour. So thank you for watching.